Have you ever known someone who seems to suddenly check out from reality? Or a student whose crippling fear of illness dictates every move they make? In abnormal psychology, we use the DSM-5 to organize and understand these complex patterns. In this lecture, we're going to focus on conducting differential diagnosis, learning how to tell apart similarly sounding conditions in three major groups: dissociative disorders, somatic symptom disorders, and personality disorders. The key lies in understanding the subtle but crucial differences in symptoms, context, and patterns. Let us start with the dissociative disorders. Dissociative disorders are defined by a profound breakdown in the normal integration of consciousness, memory, identity, and perception. When a person's sense of self or reality seems fractured, we look here first. Let us go over the key vocabulary. First, let us start with the two core forms of mental separation, the first of which is depersonalization. This is the experience of detachment from oneself, thoughts, or body, as if one is an outside observer. For example, a student might look down at their hands while typing and think, "These don't feel like my hands. I feel like I'm watching myself from the ceiling." The second is derealization. This is the experience of unreality or detachment from one's surroundings. The external world feels unreal, foggy, dreamlike, or distorted. For example, although you are walking through a familiar campus, everything might look lifeless or fake, as if you are walking through a movie set. Other vocabulary include dissociative amnesia. This is the inability to recall important personal information, often related to trauma, that is far too extensive to be ordinary forgetfulness. The next key vocabulary is identity alteration. This refers to the core feature of experiencing distinct shifts in behavior, memory, and consciousness, like having different identity states, which are also known as alters. Finally, dissociative fugue. This is a specific type of amnesia where the person loses memory and involves an unexpected trip. Now let us go over the differentiation between the disorders under this category. The main trick here is sorting out acute medical problems from trauma-related identity issues. Let us start with delirium. The core feature of delirium is that it is acute and reversible disturbance in attention and awareness, which is also linked to global confusion. An example of behavior would be a patient who suddenly becomes highly agitated, disoriented to time and place, and cannot follow simple instructions after starting a new medication. And so, the biggest clue for delirium is its sudden, rapid onset. It often happens over hours or days, unlike most mental illnesses. Crucially, it's caused by a medical problem, like infection, medication side effects, or drug withdrawal, and it is reversible once that underlying cause is treated. The confusion is global, meaning the person's attention, awareness, and thinking are all impaired at once. The next is dissociative identity disorder. This is previously known as multiple personality disorder in the DSM-4. The core feature of this disorder is the presence of two or more distinct identity states that recurrently take control of behavior, plus recurrent gaps in memory. An example of this would be a person who is unable to recall what happened yesterday, and their friends report that they were acting and speaking in a noticeably different voice and style. The defining feature here, then, is identity alteration. As mentioned in the vocabulary, the person genuinely experiences themselves as different, separate people or identities, often called alters, that can take over control. You also see significant memory gaps for everyday, non-traumatic events, which is directly linked to the switching between these identity states. So it is much more than just memory loss. The next is dissociative amnesia. The core feature of this is the inability to recall important autobiographical information, which is also often linked to traumatic experiences, which is too extensive for ordinary forgetfulness. So, an example of this would be a person who cannot recall their name, address, or any details about their life, but they retain general knowledge, like how to speak. So unlike DID, a person with dissociative amnesia maintains a single unified identity. They aren't switching between different forms of self. The entire focus is on the loss of personal memory, also known as episodic memory, which covers things like who they are and what they did, usually around a traumatic or stressful event. They still know how to function in the world and use general knowledge, which is a key difference from delirium. The next disorder is depersonalization or derealization disorder. The core feature of this disorder is the persistent or recurrent experiences of feeling detached from the self, which is linked to depersonalization, or surroundings, which is linked to derealization. So an example of this would be, while listening to a lecture, a student feels like their voice is mechanical and unfamiliar, and the people around them seem like flat cardboard cutouts. So this disorder is all about the subjective feeling of detachment. The person knows they are the same person, and that their memory is fine. There is no significant memory loss or identity switching. They are simply observing themselves or their environment as unreal or foreign, almost like watching a movie of their own life. It's a distortion of perception rather than a split in identity or a loss of memory for past events. Now, let us move on to somatic symptom and related disorders. This group is where individuals experience physical symptoms that are distressing and disrupt their lives, and the focus shifts to the person's excessive thoughts, feelings, and behaviors related to those symptoms. The problem isn't just the symptoms themselves, but the reaction to them. First, let's go over some key vocabulary. First, somatic symptoms. These are simply the physical bodily symptoms such as pain, fatigue, nausea, and more, all of which that cause distress. Next is malingering. It is important to note that malingering is not a mental disorder. Rather, malingering is when a person intentionally fakes or exaggerates symptoms, specifically for an obvious external reward, such as avoiding work or gaining compensation. This is important to note because this is how we distinguish it from factitious disorder later on. Now let us run down the differentiation between these disorders within this category. The core differential in this group is figuring out what the patient is actually worried about, and whether the deception, if any, is for an internal or external gain. Let us start with somatic symptom disorder. The core feature of this disorder is that one or more actual somatic symptoms plus excessive disproportionate thoughts, feelings, or behaviors about the symptoms. For example, a patient with mild documented heartburn spends 8 hours a day researching cancer and demands weekly, expensive, unnecessary diagnostic tests. So the core distinction of this disorder is that the patient is actually experiencing a symptom. It could be mild, like a headache, or more serious. However, the problem isn't the symptom itself, but the focus is rather on the excessive anxiety, time, and energy they dedicate to it. Their focus is completely on the symptom that they are currently having and the fear of what those symptoms mean. Now, let us move forward to illness anxiety disorder. The core feature of this is the preoccupation of having or acquiring a serious illness, while having minimal or no actual somatic symptoms. For example, a person feels a normal twinge or pain in their side, occasionally, but they immediately become convinced that they have pancreatic cancer and spend hours researching symptoms online despite a clear physical exam showing them that there is nothing wrong with them at all. So the key differentiation here is that unlike SSD, The anxiety here is not tied to current, real, or bothersome symptoms. The patient may have minimal to no physical symptoms, but is terrified of the possibility of having or acquiring a future serious disease. Their anxiety is about a potential illness, not the symptoms they are currently experiencing. They may compulsively seek reassurance, which is known as the care-seeking type, or conversely, completely avoid doctors out of fear, which is known as the care-avoidant type. Next, conversion disorder. The core feature of conversion disorder is the altered motor or sensory function, such as sudden blindness or paralysis, that is incompatible with the recognized neurological conditions. For example, a veteran suddenly loses the ability to move their legs after a stressful event, but a neurological exam shows their reflexes and nerve responses are intact. And so, this disorder is uniquely identified by the inconsistency between the physical symptom and known medical science. The symptoms, such as a tremor, blindness, or paralysis, are very real to the patient, but a comprehensive medical or neurological workup or checkup shows that the body parts should be working fine, and so the signs or symptoms are incompatible with anatomy or physiology, and often the underlying cause is psychological stress or trauma. Next up is factitious disorder. This involves the falsification or induction of symptoms associated with identified deception to achieve the internal reward of the sick role. For example, a nurse repeatedly injects herself with insulin to cause low blood sugar, requiring hospitalization in order to just be cared for as a patient. And so, the defining feature is intentional deception, with the sole purpose of achieving the sick role, which involves being cared for, gaining attention, and sympathy. The patient knows they are lying or causing their symptoms, and they are not seeking an external reward like money or avoiding a certain situation, such as military duty. If they were, that would put it under malingering, which is a key differential. And so the goal is purely the internal psychological gratification of being a patient. As extra information, there are actually two types of factitious disorder. There is the factitious disorder imposed on self and factitious disorder imposed on another. The first involves feigning or inducing illness in oneself, while the second involves fabricating or inducing illness in another person, such as a child. Finally, we will go over psychological factors affecting other medical conditions. The core feature of this is that a genuine medical condition is present, and psychological or behavioral factors are negatively affected by its course or treatment. For example, a college student with severe asthma experiences severe frequent attacks because their anxiety causes them to avoid using their prescribed inhaler. And so the key here is the presence of a verifiable, separate medical illness like diabetes, asthma, hypertension, and so on, and the diagnosis is given because a psychological factor, such as poor coping, non-adherence, extreme anxiety, or depression, is actively and negatively influencing the course, severity, or treatment of that separate medical illness. The medical state is essentially making the physical problem worse or harder to treat. And on to our last category, personality disorders. Personality disorders are enduring and inflexible patterns of thinking, feeling, and behaving that severely deviate from cultural expectations. We group them into three clusters: A, for odd or eccentric, B, for dramatic, emotional, or erratic, and C, for anxious or fearful. Cluster A, as stated, have individuals who often appear bizarre or unusual and having difficulty forming close, meaningful relationships. This group includes paranoid, schizoid, and schizotypal personality disorders, which are characterized by social awkwardness, suspicion, and peculiar patterns of thinking and perceiving. Cluster B is characterized by impulsive, overly emotional, and dramatic behaviors that frequently lead to significant interpersonal conflicts. It contains antisocial, borderline, histrionic, and narcissistic personality disorders, often involving unstable moods, disregard for others' rights, or an excessive need for attention and admiration. Finally, Cluster C involves people with disorders who tend to be nervous and driven by a deep sense of fear or anxiety. The disorders include avoidant, dependent, and obsessive-compulsive personality. All involve patterns of extreme social inhibition, pervasive need to be taken care of, or an excessive preoccupation with orderliness and control. Let us start by differentiating those in Cluster A. As mentioned, these disorders are marked by behaviors that appear odd or eccentric. The first is paranoid PD. The core feature of this is pervasive distrust and suspiciousness of others, interpreting their motives as malevolent. For example, a coworker refuses to share any work data, constantly checks their email for signs of sabotage, and believes their boss is actively trying to poison them. The key differentiation here is suspicion without delusion. While they are constantly suspicious and distrustful of colleagues, friends, or partners, they usually retain enough contact with reality to be reasoned with. Sometimes, their mistrust is pervasive, but generally doesn't involve the bizarre fixed beliefs, which are also known as delusions, which can be seen in schizophrenia. The next disorder is schizoid PD. This is marked by pervasive detachment from social relationships. They neither desire nor enjoy close relationships. For example, a computer programmer spends all their time alone, rejects all invitations to social gatherings, and appears emotionally flat, showing no distress about being isolated. The defining feature is true indifference to social contact. They genuinely don't want or miss close relationships. They are content being a loner. This sets them apart from avoidant PD later on, who want connection but are too afraid. Schizoid PD also lacks the odd thinking and behavior seen in schizotypal PD, which we will discuss next. The marked feature in schizotypal PD is the acute discomfort in close relationships, marked by cognitive or perceptual distortions and eccentric behavior. For example, an individual wears an aluminum foil hat to class, talks to inanimate objects, and genuinely believes they can read the professor's mind through eye contact. This is sometimes seen as the milder, non-psychotic version of schizophrenia. The major differentiation is the combination of social avoidance, as seen in schizoid, plus odd eccentric behaviors and magical thinking, such as believing in telepathy or having unusual perceptual experiences. Their discomfort is driven by these strange thoughts, not simple indifference or fear of rejection. Now let us move on to Cluster B. As mentioned, these disorders involve dramatic, emotional, or erratic behaviors, the first of which is antisocial PD. The core feature is the pervasive disregard for and violation of the rights of others, which is marked by deceitfulness and lack of remorse. For example, a person racks up massive debt under a friend's name, routinely lies to everyone in their life to get what they want, and expresses no guilt when caught. The crucial factor for a formal diagnosis of ASPD is the developmental history. The person must be age 18 or older and must have shown a pattern of problematic behavior before the age of 15, which has been diagnosed as conduct disorder. Their behavior is driven by manipulation and exploitation without feeling guilt or shame. The next disorder is borderline PD. This is instability in relationships, self-image, emotions, and marked impulsivity, which is driven by a frantic fear of abandonment. For example, a woman idealizes her new partner after one date, but then violently rages and threatens to self-harm when the partner is late for a meeting. So the hallmarks of this disorder are intensive affective instability, which is also known as rapid mood swings, frantic efforts to avoid abandonment, which fuels chaotic relationships, chronic feelings of emptiness, and high rates of self-harm or suicidal behavior. This intensity, instability, and fear-driven dependency differentiated from the focused grandiosity, which we will cover later in narcissistic PD, or the attention-seeking behavior, which we will cover after this in histrionic PD. Speaking of which, let's go over histrionic PD. So the core feature of this disorder is excessive emotionality and pervasive attention-seeking behavior. In essence, they must be the center of attention. For example, a man exaggerates a minor scratch that they've gotten into a dramatic, tearful collapse in the middle of a hallway to draw a crowd of concerned onlookers. This behavior is purely driven by the intense need to be the center of attention, as discussed. If they aren't, they feel worthless. While they can be highly emotional and seductive, they usually lack the deep self-destructive anger, chronic emptiness, and true fear of abandonment that defines borderline PD. Their emotional expression is often theatrical, yet shallow. Next up, narcissistic PD. The core feature of this is a sense of grandiosity, the need for excessive admiration, and a profound lack of empathy. For example, a CEO expects subordinates to constantly praise their genius, becomes enraged when questioned, and believes they deserve special treatment because they are superior. And so the central feature is grandiosity. This is a pervasive belief in their own superiority, uniqueness, and entitlement. Their behavior is driven by the need to feed this inflated self-image and demand special treatment. They lack the self-hatred of BPD or borderline PD and the dependent approval-seeking nature of histrionic PD. They look inward, focusing on superiority, rather than outward, which is more oriented to attention-seeking in terms of seeking for validation. Finally, Cluster C. These disorders are characterized by anxiety or fear, first of which is avoidant PD. The core feature is social inhibition, feelings of inadequacy, and hypersensitivity to negative evaluation. For example, a talented student refuses to apply for jobs or present their work publicly, despite desiring success, because they are terrified of being criticized or rejected. The key difference here is the desire for relationships. A person with avoidant PD craves social connection and intimacy, but is tragically paralyzed by a deep fear of criticism, rejection, and feeling inadequate. This contrasts sharply with schizoid PD, which is defined by a lack of desire for relationships. The next is dependent PD, the core feature of which is excessive need to be taken care of, leading to submissive, clinging behavior and fears of separation. For example, a 35-year-old allows their parent to choose their career, their apartment, and their friends, and is distraught by the thought of making any decisions alone. So the behavior is primarily driven by an intense consuming fear of being alone or being unable to care for oneself. This fear leads to submissive, clinging behavior where the individual willingly sacrifices their own needs or decisions to maintain the relationship that provides care. The next disorder is obsessive-compulsive PD or OCPD. The core feature is the preoccupation with orderliness, perfectionism, and control at the expense of flexibility and efficiency. For example, an engineer is so focused on creating the perfect plan for a project that they miss every deadline because the plans are never complete or perfect enough. So the core differential here is that this is essentially an extreme personality type focused on control, rigidity, and perfectionism. The vital distinction is that this is not the same as obsessive-compulsive disorder, which is an anxiety disorder. OCPD involves traits and rules which are egosyntonic, which means it agrees with or is harmony with one's self-values, beliefs, and actual thoughts. Meanwhile, OCD involves specific, intrusive, anxiety-driven thoughts, which are obsessions, and repetitive ritualistic behaviors, which are compulsions, which are ego-dystonic, which means that the person generally views these thoughts or behaviors as unwanted or distressing because they are not congruent or in harmony with their own values, desires, and personal wants. And that is the end of the video. You've just learned to navigate some of the most complex differential diagnoses in the DSM-5. We've seen how a diagnosis isn't just about sadness or anger, but rather about the intensity of the symptoms, their duration, their context, and the specific pattern of thoughts and behaviors. If you found this lecture helpful, please hit that like button and subscribe for more deep dives into abnormal psychology. We'll see you in the next video. Thank you. Bye-bye.